Today, we will be discussing the benign paroxysmal positional vertigo. So, vertigo is an illusionary sensation of motion. Either the self or the surroundings, illusionary sensation of motion, either the self or the surroundings in the absence of true motion. Nystagmus is a rapid, involuntary, oscillatory movement of the eyeball. Vestibular system, the sensory system within the inner ear that provides the fundamental input to the brain regarding balance and spatial orientation. Positional vertigo, vertigo produced by changes in head position relative to gravity. So kung may change in head position, munang positional vertigo. Benign paroxysmal positional vertigo is a disorder of the inner ear characterized by ang benign paroxysmal positional vertigo kay characterized by repeated episodes of positional vertigo. Ang positional vertigo kay head position relative to gravity. Pero kung balik-balik siya mo ng BPPV. So, posterior canal BPPV is a form of BPPV in which ang dislodged inner ear particles in the posterior semicircular canal abnormally influences the balance, producing the vertigo. Most commonly diagnosed with Dix-Hallpike test ng posterior canal BPPV. Ang lateral canal BPPV is a form of BPPV which dislodge inner ear particles in the lateral. So, ang particles ang nimatter. Diyan sa posterior semicircular canal or sa lateral semicircular canal abnormally influence the balance system, producing the vertigo. And most commonly diagnosed by supine roll test. Kung ang posterior kay Dix-Hallpike test, ang lateral kay supine roll test. Canalith repositioning procedure or CRP is a group of procedure in which the patient moves through specific body position designed to relocate nimo ang dislodged particles within the inner ear for the purpose of retrieving the symptoms of BPPV. So, imo siya i-relocate ang dislodged particles para ma-relieve ang symptoms ng BPPV. The diagnosis of posterior semicircular canal BPPV, clinicians should diagnose posterior semicircular canal BPPV when vertigo associated with torsional or upbeating nystagmus is provoked by the Dix-Hallpike maneuver kung posterior. Performed by bringing the patient from upright to supine position with head turned at 45 degrees to one side and neck extended 20 degrees with the affected ear down. The maneuver should be repeated with the opposite ear down if the initial maneuver is negative. Kung mag-negative, pwede balikon sa opposite ear. Dix-Hallpike procedure used to diagnose benign paroxysmal positional vertigo. This test consists of series of 2 maneuvers, with the patient sitting on the examination table facing forward, eyes open. The physician turns the patient's head 45 degrees to the right. The physician supports the patient's head as the patient lies back quickly from sitting to supine position, paspas, ending with the head hanging 20 degrees na siya. 20 degrees off the end of the examination. So, nagbibitay. The patient remains in the position for 30 seconds. So, makana siya for 30 seconds. Then, the patient returns to the upright position. Ibalik siya and observe. Diha pa ka mag-observe. For 30 seconds. Next, the maneuver is repeated with the patient's head turned to the left. A positive test is indicated if any of these maneuvers trigger vertigo o malipong siya with or without nystagmus. Bakit tinala ang Ipley maneuver? The patient sits on the examination table with eyes open, head turned 45 degrees to the right. So mag-ingkod siya 45 degrees ang ija head to the right. The physician supports the head as the patient lies back. So imo sa tikon. Lies back quickly from sitting to supine position, ending with the head hanging, same magyapon, hanging 20 degrees off the end of the examination table. The physician turns the patient's head 90 degrees to the left. So right man to, gikan 45 degrees, tapos naka 20 degrees at the end. Ilibot mo 90 degrees sa left. And patient remains in this position for 30 seconds. The physician turns the patient's head an additional 90 degrees to the left while the patient rotates their body 90 degrees in the same direction. The patient remains in this position for 30 seconds and the patient sits up the left side of the examination table. The procedure may be repeated on either side until the patient experiences relief of symptoms. So diagnosis of the lateral or horizontal semicircular canal BPPV. If the patient has a history compatible with BPPV and the Dips Hall-Pike test exhibits horizontal or no nystagmus, the clinician should perform or refer to clinician who can perform a supine roll test to assess for lateral semicircular canal BPPV. The diagnosis is a differential diagnosis. Clinicians should differentiate or refer to a clinician who can differentiate BPPV from other causes of imbalance, dizziness, and vertigo. Sa modifying factors, clinicians should assess patients with BPPV for factors that modify management, including impaired mobility and or balance, central nervous system disorders or lack of home support, or an increase for falling. Radiologic test, clinicians should not obtain radiologic imaging in a patient who meets diagnostic criteria for BPPV in the absence of additional signs and or symptoms inconsistent with the BPPV that warrant imaging. For vestibular testing, clinicians should not order vestibular testing in a patient who meets the diagnostic criteria of BPPV in the absence of additional vestibular signs and or symptoms inconsistent with the BPPV that warrant testing. Repositioning procedures as initial therapy. Clinicians should treat or refer to a clinician who can treat patients with posterior canal BPPV with a Callan Leith repositioning procedure. Post-procedural restrictions. Clinicians should not recommend post-procedural restrictions after canal Leith repositioning procedure for posterior canal BPPV. Observation as initial therapy. Clinicians may offer observation with a follow-up as initial management for patients with BPPV. Vestibular rehabilitation. The clinician may offer vestibular rehabilitation in the treatment of BPPV. Medical treatment. Clinicians should not routinely treat BPPV with vestibular suppressant medication such as antihistamine and or benzodiazepine. Outcome assessment. Clinicians should reassess patients within 1 hour after an initial period of observation or treatment to document resolution or persistence of symptoms. The evaluation of treatment failure. Clinicians should evaluate or refer to a clinician who can evaluate patients with persistent symptoms for unresolved BPPV and or underlying peripheral vestibular or central nervous system disorders. Education. Clinicians should educate patients regarding the impact of BPPV on their safety and the potential for disease recurrence and the importance of follow-up. Patients with dizziness or vertigo timing. For episodic vestibular syndrome, triggered kay dips kung triggered mag-Dix Hall-Pike maneuver. So for positive, consider ka ng benign paroxysmal positional vertigo. Ming ming! But for negative, assess for any orthostatic hypotension. Kung spontaneous gani ang episodic vestibular syndrome, check for any hearing loss, So, mag-consider ka og Meniere's disease. Kung may migraine, vestibular migraine and diagnosis. Kung with psychiatric symptoms, then panic attack psychosis. For acute vestibular symptoms, kung triggered kay caused by trauma or medication. Kung spontaneous kay do hints or the head impulse, nystagmus test of skew examination. So, kung naay saccades present or unidirectional horizontal nystagmus, this is the normal test of skew. Saccades present, unidirectional, isa ka direction, horizontal nystagmus. So, consider peripheral etiology or vestibular neuritis. Pero kung may saccades, then the vestibular nystagmus, abnormal test of cues kung walay saccades. So, pasabot, central ang etiology. Stroke may be caused by stroke or transient ischemic attack. Kung normal ra, then mag-MRI. Kung normal imo hints, then mag-MRI. Nga, ano kaya ni? So, for clinical assessment of patients with dizziness, ask for the patient's description of dizziness and classify the patient into one of the 4 types. So, pwede vertigo, presyncope, disequilibrium, and lightheadedness, and classify as acute, episodic, or chronic sustained. So, kung vertigo usually 45 to 54%. It is an illusion of motion, either a self-motion or a motion of the environment, commonly experienced as a spinning sensation. Ang common differential ni BPV, Meniere's, vestibular neuritis. Kung disequilibrium or gait imbalance, mostly 16%, sense of imbalance that occurs primarily when walking. So, kasagaran kung may stroke, Parkinson's, peripheral neuropathy, cervical spondylosis, musculoskeletal disorder, presyncope or near faintness, which is 14%, prodromal symptom of fainting or feeling of impending faint, generally preceded by dimming of vision, so dark e pananaw. Kasagaran due to orthostatic hypotension, cardiac arrhythmias, vasovagal attacks, hypoglycemia, anemia, lightheadedness, non-specific dizziness, mostly 10% rani, vague symptoms, possibly feeling connected with the environment. Then, kasagaran ini for hyperventilation syndrome, anxiety, depression, panic disorder, multisensory dizziness, systemic dizziness. Ming! Ano naman coming? So, obtain a medical history focusing on the timing, triggers, associated symptoms, risk factors for atherosclerotic, vascular disease, and functional status or quality. So, episodic, seconds to minute, then possible trigger kay postural changes, standing from seated or supine position with lightheadedness, imbalance, confusion, syncope, pwede, orthostatic hypotension. So, kung episodic, seconds with fatigability, kung naay head turning and rolling in bed, possible prior head trauma, then pwede benign BPPV. Kung episodic, 20 minutes to several hours, mabot ng hours, which is spontaneous, so ganito, Meniere's disease. Episodic, minutes to hours, with migraine trigger, stress, fatigue, weather, food, vestibular, migraine. Kung episodic, pero mag-change, fluctuating severity, mag-change ang severity niya, then pwede multisensory dizziness. Kung episodic, days, fluctuating in severity, spontaneous, associated with viral infection, and vestibular neuritis and labyrinthitis kung kanisa ay viral infection. So, this usually is an reactivation of an HSV1, Continuous, kung lasting 2 hours. Spontaneous, then pwede continuous o lasting minutes to hours. Pwede transient ischemic attack. Kung continuous lasting minutes to hours, pero ma-worsen si Janen, spontaneous severe symptoms at onset, then pwede siya stroke. So, ang timing, triggers, importante o associative symptoms. So, perform a physical examination focusing on the vital signs, HENT, otoscopy, cardiovascular, and neurologic examination. Then perform special physical examination like Dix-Hall-Pike maneuver for acute episodic triggered vertigo to check for the BPPV, the most common cause of peripheral vertigo. Hints plus test of spontaneous episodic vertigo to check for stroke, and hyperventilation provocation test for patients suspected of anxiety. Laboratory testing is not routinely recommended among patients with dizziness. However, testing may be requested if there is a need to identify a definite etiology to guide the treatment and should be guided by the classification of dizziness, possible etiology, and the medical history and physical examination. For patients with vertigo, with auditory symptoms, hearing loss, tinnitus, oral fullness, pure tone audiometry speech test may be requested if available. For patients with pre-syncope, syncope, and a chronic medical condition is being considered, complete blood count may be requested. For those with probable blood dyscrasia, serum blood glucose may be requested. For those with diabetes, electrocardiogram and lipid profile may be requested. For those with cardiovascular disease, empiric trial of short course 7 days pharmacologic treatment of symptoms relief should be offered. Referral should be considered if the dizziness become more severe or did not improve in 7 days. In patients with mild to moderate vertigo, offer histamine analog, betahistine or antihistamine, meclizine, diphenhydramine, dimenhydrinate or cinarizine for symptom relief. For patients with mild to moderate vertigo associated with migraine or vestibular migraine, aside from symptom relief, offer any of the triptans as preventive medication. For patients whose dizziness is described as disequilibrium, gait imbalance, or pre-syncope, near faintness, or dizziness with anxiety attack, offer symptomatic treatment and intervention based on the underlying cause, or consider referral to appropriate specialist. All patients should be provided with health education on cause, triggers, and follow-up. All patients should be advised on appropriate diet and lifestyle modification. Depending on the nature of vertigo, educate and train the patient as canal repositioning maneuver and vestibular rehabilitation. Referral to the rehabilitation medicine may be considered. Okay ba yung book ni Regine? Non-pharmacologic management. The patient's family must also be provided with health education, identify a caregiver to assist and promote compliance to management, encourage community-based vestibular rehabilitation activities as group balance train exercise. The patient outcomes. The patient should know the nature of disease, cause, and potential complication, and develop skills in postural exercises. Decrease in frequency and severity should be expected within 48 hours. And resolution is expected within a month. 48 hours. Improved quality of life should also be elicited. Referral to appropriate specialty should be done if no resolution or progression of symptoms or impaired quality of life for more than a month. So for dizziness, the clinical practice guideline and pathways for evaluation management of patients with dizziness in the family and community practice is recommendations. Ask for the patient's description of dizziness. Classify the patient into one of the four types: vertigo, syncope, pre-syncope, disequilibrium, and lightheadedness, and classify as acute, episodic, or chronic sustained. Obtain a medical history focusing on timing, triggers, associated symptoms, risk factors for atherosclerotic vascular disease, functional status, or quality of life. Perform a physical examination focusing on vital signs, CENT, HENT, including otoscopy, cardiovascular, and neurologic examination. Perform special physical examination like isang tanaw, isang sagot na lang akin. Dix-Hallpike maneuver for acute episodic triggered vertigo to check for BPPV. Most common cause of peripheral vertigo, hints plus test for spontaneous episodic vertigo to check for stroke and hyperventilation. Provocation test for patients suspected for anxiety. Elicit red flags that should warrant referral like dizziness and associated altered mental status, loss of consciousness, and abnormal vital signs. Other symptoms like chest pain, palpitation, dyspnea, neurologic deficit may warrant referral for evaluation and management. For patients consulting via telemedicine, obtain a medical history focusing on timing, triggers, associated symptoms, risk factors for atherosclerotic vascular disease, and functional status or quality of life, and observe and conduct self-physical examinations such as vital signs, mental status, ocular and facial nerve. Laboratory testing is not routinely recommended among patients with dizziness. However, testing may be required if there is a need to identify a definite etiology to guide treatment and should be guided by classification of dizziness, possible etiology, and medical history and physical examination. For patients with vertigo and with auditory symptoms such as hearing loss, tinnitus, and oral fullness, pure tone audiometry speech test may be requested if available. For patients with pre-syncope or syncope and a chronic medical condition is considered. Complete blood count may be requested for those with probable blood dyscrasia. Serum blood glucose may be requested for those with diabetes. Echocardiogram and lipid profile may be requested for those with cardiovascular disease. For patients with disequilibrium and with an abnormal neurologic physical examination finding, CT scan may be requested. Empiric trial of short course 7 days pharmacologic treatment of symptoms relief should be offered. Referral should be considered if the dizziness become more severe or it did not improve in 7 days. For patients with mild to moderate vertigo, offer histamine analog, beta-histamine or antihistamine meclizine, diphenhydramine, dimenhydrinate, or cynarizine for symptom relief. For patients with mild to moderate vertigo associated with migraine, vestibular migraine, aside from symptom relief, offer any of the triptans as preventive medication. For patients whose dizziness prescribed as disequilibrium, great imbalance or pre-syncope, near faintness or dizziness with anxiety attack, or offer symptomatic treatment and intervention based on the underlying, or consider referral to appropriate specialist. So for the non-pharmacologic, all patients should be provided a health education on causes, triggers, and follow-up. All patients should be advised on the appropriate diet and lifestyle modification. Depending on the nature of vertigo, educate and train the patient on canal repositioning maneuver and vestibular rehabilitation. Referral to a rehabilitation medicine may be considered. The patient's family must also be provided with health education and identify a caregiver to assist and promote compliance to management. Encourage community-based vestibular rehabilitation activities such as group balance training evidence. The patient should know the outcome. Ano naman eh? Anyhow, ang importante ani is pag-ibig adto katong types of dizziness, vertigo, disequilibrium, pre-syncope, lightheadedness. Then kani medications that cause dizziness, cardiac effects, hypotension, postural hypotension, torsodipwa, ang other arrhythmias, alcohol, pwede maka-cause kay alcohol, anti-arrhythmics, anti-dementia, anti-epileptics, antihistamine, sedating, antihypertensive, anti-infectives, anti-Parkinsonian agents, ADHD agents, digitalis glycosides, dipyridamole, narcotics, nitrates, PDE5 inhibitors, skeletal muscle relaxants, GL2 inhibitors, urinary anticholinergics, central anticholinergic effects, skeletal muscle relaxants, urinary and gastrointestinal antispasmodics, cerebellar toxicity, anti-epileptics, benzodiazepines, and lithium, hypoglycemia, anti-diabetics, beta-adrenergic blockers, ototoxicity, aminoglycosides, anti-rheumatic agents, bleeding complications, anticoagulants, pulmonary suppression, anti-thyroid. So, ang red flags among dizziness, altered mental status, transient loss of consciousness or unwitnessed fall, headache, neck pain, chest or back pain, abdominal or back pain caused by ruptured ectopic pregnancy, aortic dissection, dyspnea by pulmonary embolism, pneumonia, anemia, palpitation, arrhythmia, vasovagal syncope, panic disorder, bleeding or fluid losses, hypovolemia, anemia, new or recent medication use, medication side effect or toxicity, fever, chill, systemic infection, acute bacterial labyrinthitis, cephalitis, mastoiditis, meningitis, abnormal glucose, symptomatic, hyperglycemia, diabetic ketoacidosis, focal neurologic deficit, stroke, transient ischemic attack, cerebral or brainstem tumor, ear pain or discharge, acute otitis media, acute bacterial labyrinthitis, central vertigo, vestibular migraine, vomiting, vestibularitis. So for the pharmacologic options and for symptomatic treatment of vertigo, betahistine, pwede 24 mg BID or 16 mg TID for 2 months for episodic vertigo. Prochlorperazine, 5 mg orally every 8 hours. Vestibular suppressant, diazepam, 2 to 10 mg orally or IV 4 to 8 hours for severe cases. Dimenhydrinate, 50 to 100 mg orally every 6 hours. Diphenhydramine, 5 to 10 mg orally every 6 hours. Meclizine, 12.5 to 50 mg orally every 4 to 8 hours. Sinazirine, 150 mg orally for 12 weeks. Sumatriptan, mga triptan. Sumatriptan, naratriptan, zolmitriptan. Sumatriptan, 25 to 50. Kung naratriptan, 2.5 mg. Kung zolmitriptan, 2.5 to 5. Amitriptyline, 10 to 25 mg. NSAIDs, naproxen, ibuprofen, aspirin, paracetamol. Diemetics, metoclopramide, 10 mg. Domperidone, 10 mg every 8 hours. Okay. So, the peripheral and central cause of dizziness. Kung peripheral cause, consider abnormalities in the peripheral vestibular system, semicircular canal, saccule, atrial, vestibular nerve, benign, paroxysmal positional vertigo, vestibular neuritis, Meniere's. Kung central causes, vestibular migraine or vertebrovascular ischemia. Kita kayo. Yung tinnitus, tapos sabi na lang, ay vertigo, tinnitus, Meniere's. Kung Meniere's, triggers, advise patient to keep diary for possible triggers, diet and activity. Kung sa may diet, ideally limit 1,500 to 2,300 milligram of salt as recommended. Get adequate sleep, exercise, stress management, join support groups, low salt diet, avoid excessive caffeine, drink a lot of water, and avoid sugary beverages. Okay. Sa pamaro to.